Good morning, everyone, and welcome to Neurosurgery Grand Rounds at the Seattle Science Foundation. I hope you are all safe and warm on this wintry morning in Seattle. We are delighted to have Dr. Nora as part of our neurosurgical team here, and very pleased that he's going to be giving us grand rounds this morning, talking about Parkinson's disease and intraoperative techniques for the future of Parkinson's disease. Dr. Nora did his neurosurgical training at GW in Washington, has been in Seattle since 2002 and has done over 650 deep brain stimulation cases for movement disorders. So he's clearly an expert in this field, and I'm very pleased to have him with us this morning to give us the updates on this topic. Pete, take it away. Thanks so much.
Great. So thank you very much, Cam, and make sure I have control of the screen. So again, thank you, Cam, and thank you to Dr. Radescu and all the folks at SSF for allowing me to talk about really what's been a passion for me for a couple of decades. I have no disclosures, but I want to thank both the folks at Medtronic and Boston Scientific for providing some of the visual content to help with this. So it's interesting how I came to DBS. I like to say it found me, I didn't find it. In my training, I did a lot of stereotactic procedures, which really came down to biopsies for brain tumors, but it was lots of frames, understanding stereotaxis, and it wasn't really until the very end of my training and really the start of going into practice when I started to see the power of DBS for really a terrible disease in Parkinson's, how much a difference it could make in terms of quality of life. So I have a couple of slides here that are just kind of timestamps for me, which is when I was in my start of my training in the early 90s, this was the incredible mobile phone we had on the left, which about all it could do was talk to people. And now we find ourselves in 2022 with devices that not only allow us to talk, but they really do amazing things that I think we take for granted. There's talking, reminds us to get up and exercise. There's biometric data that it collects. It can do a pulse ox, it can do an EKG. We're kind of tethered to these things, but really in terms of the technological change, even in 30 years, that watch that we all wear on our wrists, I'm sure most people have on their wrists right now, back in the early 1990s would have been about $130,000 worth of electronic equipment that now is at our fingertips, which we wear every day. But I want to use this as the context for what we're going to talk about at DBS, because I want to make it more about DBS and where I think the future of going of how we're going to interact with the brain as a neural network. So who knows exactly where we're going? I think just about everybody in the audience recognizes our friends Zuck and Morpheus and the movie The Matrix. And I hope that the future isn't about us wearing goggles for our experience, but in essence, if a cell phone in the 1990s interacted with a neural network acoustically, and an Apple Watch today can interact with our neural network in many different ways, there are things in the future that are really going to be spectacular we can't even foresee of how we're going to really understand the brain in very different ways. So again, I'm going to suggest that really deep brain stimulation has some uniqueness in the entire medical world, because for Parkinson's disease alone, since its inception, there have been about 160,000 placements of DBS worldwide. And if you think about that, that is a wire deep within the brain to the basal ganglion nuclei. And really, it really is unique. It's unique, and we have the ability to study it, not just clinically, but electronically. We're going to see how it could play a major role in not just Parkinson's disease, but other diseases in the future. So I think a brief historical pathway is worth discussing before we kind of move forward. And we can go further back in history if we wanted to, but I think this really represents the modern era, which led to where we are today. And, especially when we think back to two kind of critical times when we're kind of moving away from destructive procedures like pallidotomies in the late 60s and then the early 80s. And if you notice this change from 1968 to 1987, that's an awfully long time, over a decade of really development, really close to 2 decades. And I mention that because in the mid-60s, the development of L-DOPA, which we know commercially as Cinemet, a lot of physicians and researchers felt that we can give this medicine called L-DOPA. It can get into the brain. It can increase the amount of dopamine, and we can basically cure Parkinson's disease. It wasn't until about 5 or 6, 7 years after people took prolonged L-DOPA that we realized there were significant side effects called dyskinesias, and it did have a limited range of use in terms of a time horizon. Now, to be clear, we use L-DOPA consistently and will continue to use it in the future. But there was this period in the late 60s where truly people thought that Parkinson's was going to be cured with medication, pharmacologically. Now, I point out in 1987, and Dr. Louis Benabid, who is probably the most famous present-day neurosurgeon in France, because it was really his work that ushered in the era of deep brain stimulation for surgery. So moving away from ablative procedures. And we'll come back to this timeline, but we're going to talk about the mid-1990s to early 2000s as really when things started to change in terms of what we were doing. Now, I want to put up, this is a little bit for humor, but also to understand that if we go back as recently as the mid-1970s, this is how we imaged the brain. And I am old enough to have worked with surgeons who said, yeah, this is really how this was our stereotaxis back in the day. And on the left, you have a radiologist doing a lumbar puncture, injecting air into the lumbar theca. You have a patient in a chair with a stereotactic frame on his head under anesthesia. And by putting air into the subarachnoid space, able to get an image of the brain, which you see on the right, which we used to call a rentgenogram in the day. Now we call that an X-ray, but this is really how we were localizing structures in the brain, very indirectly. And an air pneumoencephalogram allowed you to see the anterior and posterior commissure of the thalamus, but our decisions were all made off of calculations off that ACPC line, which we all know that there's heterogeneity from brain to brain to brain. So it was a very kind of crude, indirect way of trying to measure structures in the brain that you were going to try to approach stereotactically. In this era, it was more about ablative procedures for neuropsychiatric disease, not movement disorder, but it's important to understand that this isn't surgery from the early 1900s. This isn't early 1970. This would have been how we did stereotactic localization. So just some more timeline. Implantation of DBS at the start of the century was approved for essential tremor and Parkinson's disease. By the time we get to today, obviously indications have changed, and we're not going to really talk about these other indications in case there's specific questions at the end. But now you can see that this includes an additional movement disorder of idiopathic dystonia, also treating epilepsy, and there's non-motor disease that's also being treated with deep brain stimulation, obsessive compulsive disorder and severe depression. In terms of the incidence of the disease, essential tremor is essentially 10 times as common as Parkinson's disease, which is probably 50 or to 100 times more common than idiopathic dystonia. Although essential tremor is much more common, we have vastly more experience with treating Parkinson's disease with DBS than we do all of the rest of these combined. So Parkinson's disease is the most well studied in terms of DBS. It's interesting because there's motor symptoms, which we'll go over in just a bit, and there's also non-motor symptoms. And as I just alluded to, there's 160 implantations worldwide, which gives us a great reservoir of patients to basically look at and study. So again, let's just get ourselves up to speed. I know this is a learned group who knows this, but it's important to go over why we consider doing this surgery in the first place. So when I was going to medical school in the 80s, we didn't have the internet and we didn't have YouTube videos. We often used a famous textbook with basically images that were drawn and an author by the last name of Netter. And this would be something we would have looked at to basically understand just visually, if we didn't have patients, if we were first and second year medical students, what Parkinson's disease looked like. So how do we make a decision to proceed with DBS? Well, first of all, we want to make sure this is Parkinson's disease and nothing else. So that's obviously an exam that's performed by a neurologist. It's usually a movement disorder trained neurologist. And we want the disease to have basically been diagnosed and treated for about 5 years. Why not approach surgery earlier? Well, there are a group of diseases called Parkinson's plus syndromes. Probably the most common one people would know is multisystem atrophy, where it can look just like Parkinson's disease. But unfortunately, not only does it not respond to DBS, but it's a much more progressive disease, which tends to kill people within 10 years of diagnosis. So certainly we want to make sure that this is Parkinson's disease and nothing else. We want to make sure that patients are still responsive to L-DOPA. We know that if they don't really have good responsive to medication, they're not likely to have responsiveness to surgery. We want to make sure that medicines no longer work. And medically intractable can mean that medicine is just not giving them good relief of their motor symptoms, but also the medicine's making them sick in other ways. And we'll see in a video at the end that part of what this disease can be is that the medicine is just making people move too much, which is called dyskinesia. We also want to make sure there's a significant cognitive impairment. There can be depression, there can be anxiety, but we don't want people with early cognitive decline because the surgery in and of itself is likely to worsen their cognition. That would be true of all brain surgery, but we see it in DBS as well. We want to see motor fluctuations, which means a patient, when they're taking their medicine, it's working, do quite well. But then when their medicine wears off, they start to get more sick. They get much more disabled by their symptoms. The more they fluctuate, the better a candidate they become for surgery. Just as a reminder, the 3 hallmarks of Parkinson's disease are tremor, bradykinesia, and rigidity. We can have patients who are tremor predominant, bradykinesia predominant, or rigidity predominant. And based on the set of symptoms they have, it might change where we target the brain. We have 2 main nuclei we use, the subthalamic nucleus and the globus pallidus internus. So based on their particular set of symptoms and other factors in their clinical history, we may choose one target over the other. So we're going to kind of bring ourselves quickly now into the modern era. So this would be late 1990s, early 2000s. Dr. Benabid has done this work, and there's a feeling that this really is going to be the future. The FDA still has not fully approved this procedure for Parkinson's disease, but there was this idea that lesioning of the brain, destroying tissue, was not really tour de force, and we're going to call this the modern era of neuromodulation. Basically, using electric energy to basically modulate how neurons fire. It was going to be important to still use stereotactic frames because these are small targets. We're going to see the subthalamic nucleus, just how small it is in a second. Surgery generally was performed awake, and awake because these small targets required to know that when you were putting in this electrode, was it in the right place? And if it was in the right place, were we sure that it wasn't going to cause unwanted side effects from adjacent structures? So the 2 main technologies that allowed this to happen were improvements in image guidance, which we're all familiar with. Our brain lab stations are stealth stations. And it also allowed us to look at the nuclei directly with MRI scans, meaning the idea of an air pneumoencephalogram, which was very indirect targeting. We could use some of those formulas of how do I measure this and get to the nucleus, but we also could directly look at the nucleus with MRI scanning. Also, very importantly, Dr. Benabid's work on basically using very small microelectrodes to listen to both single and multi-unit recordings of the neurons, they could be consistently and safely obtained, which was very, very important in anatomic localization. So I put this slide in really just to clarify for the group, and this is kind of a coronal rendering of the subthalamic nucleus, and the purple lines that you see are actually electrodes being placed. So this is a small nucleus. Let's call it a small blueberry, maybe a lima bean. But not only it's a small target, which we can get to, but there's some very important structures in and around. The red nucleus, the substantia nigra, the internal capsule. All these are important structures, obviously, but they're also sensitive to electrical stimulation. So getting these electrodes in the right place is important as it relates to side effects. Also, every nuclei has a long axis. When we're placing these, we have to take into anatomic considerations of how do we place this safely? What cortex are we going through in the most safe manner, yet to get the longest axis of a nucleus to get the most flexibility for programming? So again, stereotactic guidance and image fusion. Placing a stereotactic frame on a patient, performing a scan, and then being able to basically localize nuclei in three-dimensional stereotactic space. That can be done by putting a frame on a patient, having them get an MRI scan and come to the operating room. But what image fusion allowed us to do is get an MRI scan days, months, weeks ahead of time. The day of surgery, put on a stereotactic frame, then go to a CT scanner the day of, and then use technology to fuse those images together. So you're basically pulling that MRI scan into three-dimensional space, and a CT scan is much more time efficient the day of surgery. Now, a little bit more about microelectrode recording. So through our burr hole, with our patient awake, we're able to place microelectrodes and literally listen to single unit and multi-unit potentials. This gives great electrophysiologic and anatomic detail, which helps us to understand where we are in the brain. So I plan my target, and I know that when I'm 7 millimeters above target, if I've done this correctly, I should actually be able to hear signals consistent with the subthalamic nucleus. The tips of these electrodes, these recording electrodes, are only about 250 microns, so they're small. So incredible technology if you think about this rigid electrode going through and being able to pick up signal and multi-unit potentials at depth. This can be done with multiple electrodes coming in at once, so you can create a three-dimensional map. It also can be done with single microelectrodes coming through to do the same thing. But this is advising where our permanent electrode is going to be placed. So in essence, as I'm passing my microelectrode through my burr hole, again with the patient awake, I expect along my pathway to see very distinct signatures as I move deeper and deeper, and I can record these, and not only a visual signal, but the actual acoustic signal that we hear makes a difference in where we think we really are. But obviously, Dr. Benabid's work was able to make this happen and absolutely transformed our ability to understand where we are in three-dimensional space. It also was really the fertilizer to study the brain in a way it never had been, with single unit and multi-unit potentials in a very, very discrete area. On the right, there's kind of a rendering of a coronal view. And again, 3 microelectrodes coming in, again, helps us define which one of these pathways we might want to use, depending on which gives us the longest axis of STN signal to place our electrode. Now, as we're going to talk about in a moment, placing sharp, pointy objects in the brain is generally something we try to avoid. So this is great information, but we also want to minimize the amount of these cannulations, again, which we'll talk about and how technology has helped us do that. So briefly getting back to the historical pathway, we're going to kind of move now what I would consider truly the beginning of really changes that was the real integration of DBS into the neural network. So in 2008, a study at NIH of subgroup of neurologic disorder and stroke, along with the largest North American study, which was a veteran study, confirms that DBS is superior. And superior to what? It's superior to DBS plus best medication versus best medication alone. And that's very important. DBS was never really thought of something that could replace medication altogether. But if DBS allows medication to work better, or we can use much less medication to get the same effect, Obviously, that's a superior in terms of patient outcomes. So this was very important, realizing that this was no longer really experimental surgery in any way. This was clearly the best route for patients who had become medically intractable. So I started performing DBS in year 2000, and we had this decade of doing surgery, and it was very rewarding, but there were still tremendous challenges. We had great success, but we also had tremendous frustration in terms of why were some cases seemingly a slam dunk? Why were some cases, gee, this didn't really end up where we thought it should be? And we had to overcome those challenges to really get to where we are today. And this is really what the talk is about. The first time is, how do we take modern technology to get us to a better place? Well, the first is intraoperative imaging. We all understand what intraoperative imaging is. But in the 2000s, having reliable intraoperative imaging in the operating was rare. Intraoperative MRIs were rare. Intraoperative CT was rare. And although certain centers were able to create surgery within the MRI scanner, it was cost ineffective for a number of different reasons, let alone the equipment, the anesthesia, et cetera. So there are imaging platforms that exist. I think we'd agree that the cost constraints on a number of different ways of the MRI scanner are high. For the CT scanner, although more common, it still is a cost constraint, even with a mobile CT scanner of having it in an operating room. And from a facility point of view, how easy they are to use, how big is the bore, how well does a frame fit into a CT scanner, are all specific challenges that made it more difficult. So O-arm technology is basically using X-ray technology to help localize particularly bony anatomy, but really the advent of this and being able to use the O-arm in the operating room, again, through this fusion technique, since an O-arm really isn't looking at soft tissue anatomy. But if you could take data from an O-arm scan in the operating room and you could fuse it back to CT scanner data or MRI scanner or both, it could be potentially very powerful in having real-time intraoperative imaging in terms of advising your electrode placement. So what are the benefits of this technology if it works? Well, there's a much lower entry cost, not only from the machine itself, but sort of the requirements of having it in the operating room. The cost per use is less. You can use an O-arm across multiple disciplines, ENT, certainly a lot of minimally invasive spine surgery and instrumentation makes use of technologies, if not O-arm, that are like O-arm. It's portable, it can be taken from OR to OR. It's pretty durable. If anyone's seen a radiology tech bump an O-arm into the wall, which I've seen a number of times, I'm still surprised that it manages to survive that and still remains accurate. But the question is, was it equivalent to the MRI and CT scan? Could we show that, especially when you're talking about something like deep brain stimulation? We're talking about small targets. Minimal error can have maximal effect when we're considering surgery. Well, the good news is this issue got studied carefully and really got resolved. So this first paper from the Cleveland Clinic basically was looking at very specific issues, but really wanted to look at safety and efficacy. And basically what they found was by having the O-arm in the operating room, it reduced the number of cannulations in the brain, less microelectrode recording. Now, that's always a benefit to the patient and the surgeon to say, if this gives me real-time data, which is actionable, and I can puncture the brain less, and I can improve the speed of the case, that's a good thing. So that's been shown, which is great. In addition, and again, I would say less important, but also a good thing is, at King's College in the UK, they show that having the O-arm in the operating room reduced operative time by 68 minutes per case. That's relevant, and that's very, very important. To understand this kind of from a practical point of view, before 2015, I would do surgery with all the tools at my disposal, my microelectrode recording my awake patient. But the only way I knew where that electrode really was to leave the operating with the patient and get another CT, and if I felt, come back, which obviously adds complication in terms of time management, the safety of the patient being transported, et cetera. So just a brief picture of what my operative setup looks like. I think this is very similar to people using different types of intraoperative imaging. So on the left, we've got basically people who can interact with the patient, whether they're awake or asleep, in a non-sterile manner, for intraoperative testing, talking to the patient, etc. And on the right, this is my view. And you can see I can work in a sterile field. That's a CRW stereotactic frame. There's a microelectrode driver that's actually attached in it. And that's kind of what my workspace is, which is very comfortable. Nice thing is, I also don't really have to change anything to do my O-arm scan. So I can scan with cannula in the brain, electrodes in the brain. There's nothing that has to be changed or moved. This probably moves towards the feet and towards the head about 8 inches, and that gives me plenty of room to basically be able to work and get scans on demand as I need, okay? So we're going to talk now a little bit about what this looks like, and again, making sure it's equivalent to other technologies. So this is a recent case where I was doing bilateral subthalamic nucleus deep brain stimulating electrodes, and I was getting my scan with the patient still on the operating room table, and I just wanted to confirm my electrodes were in the right location. I'm sorry, I skipped ahead there. Let me go back. So what you're going to see here on the right, or the basically yellow path, is that's my proposed target, and you can see that hyper dense brightness there that seems to be outside of the oval ring, which confirms my electrodes to medium. So I want to corroborate with what I'm seeing at surgery, but the power to have the patient on the operating room table and to be able to have that information is really great. It's going to allow me to say, okay, I've got to consider removing my cannula and replacing my electrode to a more medial location. In this next picture, what I've done is I've not only moved the lead and only moved the lead 2.5 millimeters, I can superimpose my MRI scan over that to show me that now I'm within a reasonable range of feeling that my electrode is in a position where I think it should be acceptable based on my plan. And the time between placing my first my right side electrode, the yellow, getting my O-arm spin, and replacing it's about 8 minutes. And if you compare that to closing up the patient, going back to the CT scanner, coming back to the room, obviously we're talking about major time savings, which adds to safety and efficiency. Now, the other incredible breakthrough is really these tools we have, again, within the operating room. Because we can do intraoperative imaging, we get real-time images like this within probably 7 or 8 minutes of placing our lead and doing our O-arm spin. I'm just giving one example here of this image, which I can spin, I can look from any angle, I can do a probe's eye, etc. And this is the subthalamic nucleus. So is my electrode, which you see passing through there in the cartoon, is it in an adequate location? And this image is actually unique to the patient. This isn't like I'm going back and looking at a Shelton Brand Warren Atlas saying, do I think I'm in the right place? We're using technology to basically say, this is unique to the patient, and do we have this in an optimal location? Even as recently as 4 years ago, this would have taken processing of 30 to 40 minutes outside of the operating room after surgery. So it was a post-facto look. We don't like post-facto looks. We like being able to look in the operating room. Is this more corroboration of where we want to be? We also can get images like this in the operating room very, very quickly that let us look in 3 dimensions. How does our electrode appear to be placed compared to other adjacent structures? Are we seeing side effects that are basically corroborated by what we're seeing with the patient's own 3-dimensional anatomy? Again, really powerful information that has really come to the fore recently in advising how well and how accurately to do this surgery. So I want to briefly talk about another technological breakthrough, which really, from a surgeon's perspective, is incredible, because I think about all the movement disorder conferences I have gone to over the years with my colleagues when we're looking at patients after surgery and we're looking at the postoperative MRI scan and we fused it back, and the neurologist says, you know, I'm really struggling programming this patient. We said, well, look, we put this in the right place. Here's what we saw at the operating room. Here's what the patient, how they behave, everything looked great, but still the neurologist says, I'm not getting the benefit I want, or when I get the benefit I want, I get significant side effects. Within the last 2.5 years, that's been changed dramatically by what are called steerable electrodes. We're going to talk about that technology a little bit. This is really important for patient outcome, patient satisfaction, and even whether we make decisions to return back to the operating room to change the lead to a different location. So this rendering you're going to see here is kind of our old technology. When I say old, I mean 2 years ago, to our new technology and how it works with this cartoon in 3 dimensions. So here's a rendering of my electrode going down to the subthalamic nucleus. And whether this is the operating room or in the neurologist's office for programming, stimulation begins, and the blue is the subthalamic nucleus, but that's the internal capsule fibers, the motor fibers, and trying to get good benefit by having that electrode stimulate with pulse width and amplitude and current. Unfortunately, it can be, we're getting good benefit. We're seeing reduction in bradykinesia. We're seeing reduction in tremor, but the patient's got dysarthria or the patient's got cramping in their face. And that's because you only had so much ability to get benefit without side effect. This next rendering is actually what's called a steerable electrode. So the design itself is changed such that you can actually change your field in substantially more ways, in part because each one of these contacts, 1, 2, 3, and 4, have their own unique connection to the pulse generator that really allow for really precise stimulation. And again, tremendous technological advance, and this is really a combination of the electrodes improving and the pulse generators that power them improving too, but really only about 1.5 to 2 years old. Again, another way of looking at this is this 3-dimensional cartoon is going to show you what we call field shaping, how these new electrodes can actually, with almost infinite ways, can change the shape of that field of effect. Again, maximizing benefit with lower energy delivered and decreasing side effect. So we've gone over intraoperative imaging and basically steerable electrodes, which I'd argue are the 2 greatest changes. But another issue I want to discuss is awake surgery. And again, certainly on this call, there's neurosurgeons who do awake surgery, but awake surgery is a lot of work. It's hard on the patient. It's hard on the whole team to keep the patient comfortable. So if we look under this column of awake, the benefit of awake surgery is very robust microelectrode recordings. Right there in the operating room, I can see the tremor go away. I can see their muscles start to relax, the bradykinesia reduce. And importantly, I can see identification of side effects. I can talk to a patient during surgery. If they start getting dysarthria or cramping, I see it there. But there are some significant challenges. It's no party to be in the operating room awake if you're the patient. And there's a lot of fear and anxiety leading up to it. It certainly keeps patients from ever considering surgery. You're laying flat on the table. You're off your medication, so you're not feeling good. You're cramping, you're stiff. There's multiple electrode passes, which the patients, although it's not painful, that adds concern and anxiety. I add anesthetic concerns because if I've got the right anesthesiologist helping me do this, it can be butter. But if I have an anesthesia resident or someone who's not as skilled as awake surgery, it can really make for not a pleasant day for the surgeon or the patient. And awake surgery clearly adds increased operative time. Awakening the patient, putting them back and sedating them, awakening them. Now, to be clear, this is what we've really done the last 15 years, and there are people who are skilled at it, but there are certainly challenges. What this new technology has allowed us to consider, and consider it more and more, is putting a patient asleep under anesthesia, but having intraoperative imaging to advise our placement. Well, you control your anesthesia in a much different way. The patient's much more comfortable, obviously, and they accept this much more in consideration. It shortens our operative time. Now, you do pay a price. You can still do microelectrode recordings with the patient asleep. Clearly, there's limited evaluation of side effects because you're not talking, but you can stimulate the patient and you can see whether they've got contraction of their limbs or their face. But you don't get to see amelioration of symptoms. You can't see whether their rigidity goes away. You can't see whether their tremor goes away. So this is our mantra: safety, efficacy, and efficiency. We want to reduce cannulations in the brain. We want the patient experience to be good. We want the surgeon experience to be good. So we want to really contemplate what's going to be the best thing anesthetically for this patient. We want our neurologists and programmers to be happy that they've got a lead in a very, very good place that's easy to program and gets good control. We want to decrease our OR time and use of resources. And we certainly want to eliminate reoperations for malposition of electrodes. So that having been said, for each individual patient, we make a unique decision. What are their expectations? What are their predominant symptoms? Is it really important they're awake to see their tremor get extinguished with surgery? How important is MER? How important is awake testing, our anesthesia? And do we clearly have our intraoperative imaging? We don't want to find out the day of surgery that the spine surgeon has the O-arm and we're going to be going out this. We simply don't want to do that. We'll cancel the case because it's just become such an integral part of what we do. So for the last 10 minutes, I just want to talk about what I think is really this incredible leap and why this is going to, I hope, have greater implications for neurologic disease and how we're going to get increasingly plugged into the neural network. So open loop stimulation to closed loop stimulation. And that's going to be brain sensing. So currently, open loop stimulation means we implant the device, we program it as best we can, and we just leave it turned on, and it continues to provide therapy. Doesn't really respond to neural activity, and the patient's required to change their medication to kind of find some happy equilibrium to control their Parkinson's disease. The advantage of using a closed loop system is that that electrode actually listens to the brain. It gives some updated status of disease. It talks back to the pulse generator and says, deliver therapy in this amount, in this quantity to get us to the best possible place. Now, we can think of a cardiac pacemaker. It can be set to treat tachycardia or bradycardia. That's pretty easy. If the rate gets this high, it does something, and the rate gets this low. It's a very on-off, it's a very simple algorithm. Even neural pace for epilepsy, it's listening to an electronic signal. When that electronic signal, stimulation comes, depolarization, and it aborts a seizure. So there are examples of closed loop, but they're really, I would argue, pretty simply based. They're effective, but simply based. So the concept is changing. And the concept of Parkinson's disease is changing. And I want to use this analogy, which is not, this is not my brainchild, but it is obviously, I think, a very good analogy. Microelectrode recording, which we've used for the last 20 years, is putting a very fine electrode and listening to neurons. It's as if you were at a Seahawks game and you were listening to one fan talk, but your eyes were closed. You didn't know you were at Seahawks Stadium. And that patient was talking, and you said, yeah, it sounds like he's talking about sports, but I don't know if it's football or is it soccer? Are they winning, losing? If you could actually listen to 1,000 fans through what's called the local field potential, we're listening to a much larger group of neurons. We'd get a much better sense of what was going on in the greater network and assume this whole stadium's the brain. If we could listen to 1,000 fans, we'd know much better the Seahawks games. We know what the score is. We know a lot of things, but we'd have much better advisement of what's happening dynamically in the brain. Quickly, within local field potentials, we have these famous frequencies that neurosurgeons don't really care about. Epileptologists love them, but there are these frequencies, and they're just a frequency range. And we're going to focus on the beta frequency because that seems to be the most powerful correlative to Parkinson's disease. We can listen to the brain in multiple areas. We can listen with single unit potentials. We can listen with local field potentials. Why local field potentials become so important? Again, because we're listening to the synchronous and the oscillatory activity of multiple neurons. It's going to give us a broader sweep of what's happening. So in a nutshell, LFPs represent the natural ebb and flow of the brain, the oscillation of groups of neurons, how they interact with other neurons. And this is going to tell us a lot about brain health and disease. This gives us a much greater average and insight into the whole network compared to a single unit. Single units are great for anatomical location, but they're giving us no sensibility of the dynamism of the brain. Parkinson's disease, when you are in a Parkinson state, you've got tremor, you've got rigidity, you've got dyskinesia. We have very specific changes in the beta frequency, what's called beta power in the basal ganglia. And it has truly become a biomarker of the disease. If you can measure this local field potential, you can measure the status of the disease. This has changed Parkinson's disease from being simply, you don't have enough dopamine, to a neuropathologic disease. So not a depleted neurotransmitter disease, but basically a neurophysiologic disease. This requires substantial technologic breakthrough. You've got to be able to stimulate the brain and listen to the brain without having significant signal to noise problems. Really tremendous that you can do that and really have signals that are usable. So this is now becoming adaptive closed loop DBS. The brain senses a local field potential, it's abnormal, it's consistent with part, and it can stimulate to effect. A trial has been begun throughout the world with 12 centers really trying to quantify the benefits. It's called the Adaptive Stimulation Trial, begun in January of 21. And it's really trying to quantify the safety of adaptive stimulation to that conventional set it and forget. It's on, and that's all I can do is be on or off, which is what we're doing today. So imagine that using this technology now advises the whole system, the whole stadium that I just pointed out in a different way. Okay? It can really allow us to much more integrate in not just what's happening in the nucleus, but all these known pathways and how it could basically advise other types of diseases. Now, there is a hard part coming. This is exciting because now we're going to have smart pacemakers, smart DBS. But we have to make sure it's safe and it's equivalent to what we're doing now. That's going to happen, I think, shortly. But there's a massive amount of collection of data that has to occur. We're going to stream live data. Programmers, neurologists, mid-levels, be working with patients in clinic to basically say, well, I've got all this data of what was happening. Now let me see your diary of how you're experiencing your Parkinson's disease. Wearables, ergonomic gyroscopes like the Apple Watch have to provide objective data. Is the patient just walking? Are they having a tremor? Or are they having dyskinesia? Those are very different physical issues, which have to be defined basically from a local field potential. But if we're able to integrate these data sets, that's going to take a lot of computing power. We're going to, for the first time, be able to dynamically treat movement disorders. And that will really be phenomenal. But it is going to take a tremendous amount of work and integration of data sets. So, quickly, the benefits. We have a real-time measurement of a biomarker of disease, not an electronic measurement, but a true biomarker. We can measure how well DBS works by how much we basically suppress the beta band. Automated therapy would basically say in real time, does this patient need a little stimulation, medium, or high, based on an algorithm that's built into their generator. That means better control of the disease, less medication, better life, and less need for pulse generator replacement because they're going to use less energy with better control. So in essence, we hope, and again, it's a hope, that this really allows us to understand in a very different way how to measure disruptions in the neural network. That's disease. We're focusing on movement disorders now, but I really believe this is going to have an outsized impact on behavioral psychiatric disorders. Think about depression, obsessive compulsive disease, and perhaps even neurodegenerative disease, because we think stimulation, but these devices are now going to listen in real time to the nuances of local field potentials, which are going to have ramifications throughout all areas of the brain, not just the basal ganglia. So in brief, it's an exciting time. Most people think that DBS is pretty boring. I don't. I think it's fantastic. And technology is making my life better, and it's making patients' life better because less and less reoperations. And that's in part because I think I'm placing better electrodes using this technology. I get to do it now more asleep, which is allowing the bar for entry of more patients to have surgery. There are many, many patients who would never consider DBS surgery because of being awake. That's great. It's also allowing my neurology colleagues who are critically important to have more flexibility with programming with cerebral electrodes. I can use cerebral electrodes in the operating room, and programmers can use it in the clinic. Now that we know that we have a biomarker to correlate severity of Parkinson's symptoms, we are going to get more precise treatment of this disease. It's going to be proven. I really believe that. I can't say it definitively, but I believe it's going to show that. And that's going to be better for this disease, which I truly hate. Adaptive DBS. It senses and it stimulates. Is going to, I think, unlock a much greater understanding of pathophysiology. It's like real time listening to the brain electronically, and with computing power, we're going to be able to process all this data. I hope it gives us a greater understanding and how we can learn how things disrupt long before diseases become severe. So in closing, we can no DBS surgeon can ever go through a talk without showing you some video about patients. And I chose these two patients for two reasons. They're young. They had bad disease in their 40s. We think of this as an old person's disease. It is not an old person's disease always. Median age of onset is in the mid-60s, but these two gentlemen I'm going to show you are in their 60s and show you how much the disease impacts and how much DBS impacts improvement over that. So this first one is classic tremor, rigidity, and bradykinesia. On the left is the day of surgery. On the right is 2 months postoperatively. The second patient I want to show, and this is again for the students and residents who might be listening, is Parkinson's disease can be a disease of too much medication, dyskinesia. You're going to see in our second patient in his 40s, he's taking so much medication to continue to move that he's walking with dyskinesia, and 2 months after surgery, how much more normal his movement is. Sorry if the video is a little staccato here. So this gentleman is 45 years old on the day of surgery. And this patient now, I want you to look on the left. This is how is pictured in his apartment 2 days before surgery with dyskinesia. He basically would take 12 pills of Sentiment, put them in Kool-Aid and take sips of it all day. And that second picture of him walking was in the clinic. He was getting ready to go up to Crystal Mountain to ski for the day about 3 months after surgery. So really phenomenal. So thank you for tuning in. I hope I provided some insight into the technology, kind of the historical precedents that came before. It's really important that I thank my colleagues on the neurology side, Drs. Kamani, Beshra, and Liu. It does take a village to take care of these patients, both before surgery, during surgery, and after, and we couldn't do it without their collaboration. My partner, Tony Wong, in neurosurgery, phenomenal functional neurosurgeon, and our two mid-levels, Martha Short and Melissa Payson, who help us with patient care all the way through the process. So again, thank you for the opportunity, and certainly be happy to take any questions.
That was terrific, Pete. Thanks so much. It's always been a little bit difficult for me to sort of really understand what's going on with this. As you look at the timeline, and things really started taking off when I was finishing my residency, and so it's always been an area that I admire but don't understand very well. What do you think? How much does this potentially open up the treatment for the Parkinson's disease patients? I mean, in terms of moving, obviously you're going to continue to optimize the medical therapies associated with it, but how many more patients do you think would be eligible for treatment as we get these adaptive closed loop stimulators, assuming that they work in the way you hope they might?
Well, thank you, Cam. It's a great question. So this has kind of been a frustration, which is, and again, these are going to be rough estimates. So there's 1 million people in North America with Parkinson's disease, and conservatively, 10 to 50% of those are candidates for DBS based on criteria, well understood and studied criteria. Of that group, probably only about 5 to 7% consider DBS. And I won't bore you with the details for that, but I think one of the major barriers is awake surgery. And I think we're trying to kind of get it. trying to find that sweet spot of where to use awake surgery and where to use a sleep surgery with intraoperative imaging. I think this technology is going to be available to any patient with classic idiopathic Parkinson's disease. And I think what's going to happen is I just think some of the frustrations of the waning effect of the DBS or running out of ceiling with medications, I just think they're going to get a much better treatment in real time and a more durable treatment. I want to be a little careful how much I sort of, step on this question is to say,
Yeah.
If you see DBS patients and you see a home run, you say, gee, that's a home run. They dropped their medication substantially. The DBS is working. It's hard to tell they have Parkinson's. But there's a greater proportion who say, I kind of have brittle Parkinson's disease. Sometimes my stimulator seems to be doing too much. I don't know whether to lower my medication. Am I having a good day or a bad day? Those are the ones that struggle. Those are the ones, and I think that represents the majority of patients, right? I think they're just going to have a smoother treatment, which is from a quality of life perspective will be fantastic. So I don't know that it necessarily enters more people into the portal, but I think the quality of their treatment really does change.
Predictability for them, where they're able to sort of not wake up in the morning and wonder if they're going to have a day where they can function or not. Yeah. I want to open it up to the other panelists and anyone else. Is there any questions there? There is, let's see, let me look at the chat here. Do MEs have the capability of recording the LFPs over a small and wide range? How wide a field can they record?
Great. So that a little of that's to be determined. We think of it in the region of the LFPs. And again, I want to be clear about LFPs. To be able to stimulate and record is different than just being able to record. There are very specific settings right now in terms of monopolar stimulation with bipolar recording, which limit all the possibilities of stimulation. But the idea is that local field potentials are going to be able to look up and down the length of the electrode and say, where is really the beta power the highest, right? This kind of used to be done indirectly where a patient would go to a neurologist's office, they would try all the electrodes, which was called electrode review, and say, okay, this seems to be the area where you're getting the best effect. Go home, come back in 2 weeks, and we'll see how you're doing. It's kind of very indirect route. Now, you're actually using neurophysiologic data, which we're going to say is within millimeters of the electrode, right? Giving you a real local field to understand if you use that electrode, you're going to extinguish that beta power or reduce it. And you can do it dynamically because beta power changes whether a person's awake or asleep, if they're having Parkinson's symptoms or not. It's not that there's going to be improved localization, but there's going to be improved dynamism. I look at it as local field potentials in the neurologist's office is within millimeters of the electrode. In the operating room, presumably, you could do it over a greater range because you're not stimulating in the same way. But it's just that dynamism that's going to be so important to see if that really does, it really is a game changer in treatment.
Great, thanks. Just reading directly from the chat here again, wondering if the stimulation stop the STN from working or make it more active?
Okay, that's a great question. So the simplified answer is always stimulation depolarizes the neurons. The subthalamic nucleus is a GABAergic nucleus primarily, and by suppressing those inhibitory neurons, we bring back into equilibrium normal movement. It is more complicated than that, and probably outside of the halo of that inhibition, there's probably some stimulation. Again, do I think LFPs answer that question? Not necessarily, but I think we know that there is depolarization, which leads to clinical benefit. But clearly, there are probably some effects of stimulation that occur also outside the nucleus that add to benefit and can add to side effect for that matter too. So simple answer is depolarization, what you talk to a patient about, but it is a more complex neurophysiologic issue, how stimulation truly works.
So off topic, but I'm really intrigued by the use of these technologies for depression and obsessive compulsive disorder. It just seems like such enormous potential. What do you, where,
Well,
what
yeah,
are you
and
thinking about that
great question.
future?
So I was involved with the trial back 10 years ago, and the target for that trial was based on a lot of functional MRI scanning, right? Basically, taking depressed patients, trying to find common pathways that seem to be, for no better, we're lighting up where there's hyperactivity that was consistent with depression, anterior thalamus, subfrontal regions. And so in certain patients, by placing electrodes in that area, causing inhibition, certain people got benefit, but many people didn't get meaningful benefit. And the bar for benefit is very high as far as the FDA is concerned, right? No, super sick depression patients. Why this is exciting is if we can define depression with a biomarker, not looking at a functional MRI, because a functional MRI doesn't really speak to recurrent circuits and the dynamism of the neural network. But if we consistently say, this biomarker, is it the theta, is it the delta, is it the beta, and this consistently equates to a depressed state, now you have a very different way of looking at the disease. You're not looking at the disease electronically, you're not indirectly looking at functional MRI, you're saying, we can consistently show that this is what's happening in the nucleus or the region at the time of depression. So I think there's huge potential. But as I said before, the hard part is integrating all this data. Part of it's subjective data from the patient too. But do we have the computing power to do it? We will have the computing power to do it.
Yeah, it's a very exciting frontier. Any other questions from the panelists?
Just in the same lines, great talk. Cameron stole my thunder, but I was going to ask more about addiction, actually. I'm not sure if, we talk about depression, but for me, I think the money and the FDA would love something for addiction, especially for opioid use. So I wasn't sure if there's grants and things like that available.
These are still really, these are still really off-label. We're really talking about done much more in Europe and the US. And look, there is a body of data to suggest where addiction centers are, but I hate to say it, it's kind of in addiction. It's been a little bit of hunt and peck. We know where the nucleus accumbens septi is. We know how to get there. We can get there. Safety is the reward center. Is that holistically the answer? It's hard to say. I just, again, we need medical clinical correlation with what is happening electronically in the brain. I mean, a single unit potential lock shell does give you some information, but it does not really speak to the neural network. Local field potential is starting to now look much more broadly, but it is not perfect either. It still gives a limited range, but it starts to help us understand all these recurrent circuits. The basal ganglia used to be about movement, right? It's all about movement. Well, now we know the recurrent connections affect every region of the brain, emotion, reward. So it's an exciting frontier, but it can be very, very daunting getting the clinical data to show that these work. But a great question.
All right, I think we're at time. Thanks for a great talk, Pete. Really appreciate it. And hope everybody has a great day. Thanks for attending. Bye-bye now.
Bye-bye.